his name? Tom Belly. Oh my goodness.
Welcome to those of you who are joining us on live stream. We just have some people entering the auditorium, so we'll be a couple of minutes late in starting. There's lots of seats up front. To those of you who are joining us on live stream, we're just going to be a couple more minutes. Arturo, you're going to be stuck in there. You're going to be stuck. Hi, how are you? How about just right there in the front row? No. I got the front row for you. That's my chair right there. You can't sit in that one. Welcome, everyone. I'm Laura Erskine. I am faculty in the Department of Health Policy and Management and co-director of the Center for Healthcare Management. And I want to thank all of you who are here in person and all of you who are joining us on the live stream. This event is co-sponsored by the Center for Healthcare Management, the Center for Health Policy Research, and the Department of Health Policy and Management. Before we begin tonight's program, I want to thank the many donors who have made the Health Forum possible. As many of you know, this program is named in honor of Paul Torrens. And Paul is now Professor of Emeritus in the Department of Health Policy and Management. For more than 40 years, Dr. Torrens guided, mentored, and advised students in our school, helping many to shape very distinguished careers in healthcare. And I could not be more delighted that tonight's event is taking place, finally, in person. And it's really wonderful that you could all join us. Jerry was on the committee that brought me to UCLA 9 years ago, and so being able to participate in this event tonight is especially meaningful for me. His career, like that of Dr. Torrens, has influenced generations of students, and I know that he will continue his influence for many years to come. A few housekeeping notes before we begin. We encourage questions from the audience, and there will be time towards the end of tonight's forum for you to ask those. And you can learn more about tonight's session by scanning the QR code, which will give you access to the bios of the speakers and tonight's agenda. It's my pleasure to introduce Jack Needleman, the Fred W. and Pamela K. Wasserman Chair of the Department of Health Policy and Management at the UCLA Fielding School of Public Health.
Okay. Thank you, Laura. It is my distinct pleasure to introduce Jerry this evening. Laura commented on the impact he's had on generations of students, but I would also say he's had an incredible impact on generations of policy. For thinking about Jerry and this tribute, I went back over his whole CV, read many of the 97 articles and the 45 or 50 published reports and policy briefs to try to understand what Jerry's career has been. And the single word that sort of came out for me in reading through that and thinking about the Jerry I know is impact. And there are some fields where the goal of scholarship is to expand theory or to just elucidate some interesting thing about the thing you're studying. But in our field, the goal of nearly everybody I know is to have an impact on the world. And Jerry's scholarship has done exactly that. To have impact, you need to do research on questions that are worth asking. You need to, if you're doing research on policy, understand what the policy is intended to do, and then do analysis with a level of rigor and intensity that will tell you what the policy is actually doing, to understand why those discrepancies exist and who gains and who is disadvantaged by the difference between what the policy is intended to do and what it's accomplishing. And as I went through Jerry's publications over and over again, that's what his research has been about. It goes back to the first papers he did on DRGs and the unintended consequences of some of the methods that were used in DRGs. It goes to looking at, later on, the resource-based relative value scale for physicians and understanding the difference between what was intended and how what the methods that were being used resulted in. It's examining things like case management research programs and understanding whether they are accomplishing what people hope. There's this extensive research on the Affordable Care Act, which is the subject of today's discussion. And it goes back to the period before the Affordable Care Act was enacted to think about the intent and how it was being shaped in design. And then after, in detailed, extensive analysis of what the program's actually doing, and modeling how it is performing so that California's policymakers can make the right decisions. It is an impressive list of activities and research that was completely focused and successfully focused on creating impact. The Center for Health Policy Research asked me to think of a word that described Jerry. And the first word that came up was not impact, it was generosity, it was generousness. Jerry is an incredibly generous person. He's generous as a friend, He's generous as a scholar. He's generous as a colleague. And that generosity shows up in many, many ways. But as I reflected on generosity in Jerry, I also realized how much the ways in which he has been generous have also created impact. He's had an amazing impact on students, which Laura referred to, in terms of many, many doctoral students and many master's students who have developed skills that transcend the classroom from working with him. He's had an impact on younger colleagues as a mentor and as a collaborator in research. Folks like Dylan Roby and Nadi Parat, Ying Ming, who's here, Karina Mushiro, who's here. And of course, any team that he has worked with, including the work I saw him doing as a mentor and leader of the California Simulation of Insurance Markets modeling exercise, where he forced people to confront issues that they needed to confront and supported them as they learned what they needed to do in order to do that. Jerry's generosity has included commitment to the institutions that he's been in. The Center for Health Policy Research, first as the associate director and then the director. The creation of the Health Economic and Evaluation Research Unit within that center. He was one of the first people working on the California Health Benefit Review Program and helped shape the way that program goes about its work in influencing legislation and policy in the state. He's been active in influencing the construction and the way the School of Public Health operates, not only in recruiting extraordinary faculty for us, but also as an associate dean and as a critical member of the faculty in the Department of Health Policy and Management. He worked for, working with Robert Wood Johnson Foundation, he worked with the Meharry School of Medicine to help them develop and cultivate a health policy capacity and a health for the medical students there, a critical need in building expanded capacity even outside of UCLA. And finally, I would be remiss if I didn't mention his endowment of a scholarship for first-generation students in the MPH program and the incredible both generosity and impact that that will have. So with that, let me stop introducing Jerry and give him his chance to come up here and tell us and speak to us about what we hope to accomplish here tonight.
Jack, thank you very much. Thank you for that wonderful tribute. And now it's time for me to pay tribute. There are so many people I'd like to thank for the wonderful career that I've had at UCLA. Most importantly, I'd like to thank my wife, Laurie, and our daughter, Julie. Who've always provided me with the perfect balance between family, life, and career. Without their love and support, I can honestly say that I would not be here tonight. And because there are so many other people I'd like to thank, but not enough time to do so tonight, I filmed a tribute video several months ago to honor those who've been most influential in my personal and professional development at various stages in my life. Now, that video is still in production. But I hope it will be available online soon. I understand that there's the producers have a conflict. They want to recast the lead role. So, in lieu of the tribute video, tonight I'm going to focus the first part of my allotted time paying tribute to the two people who were most influential in my life from the beginning. My parents, John and Marie Kominsky. Here are my parents on their wedding day, June 12th, 1943. My father was 25 and my mother was 20. Neither of my parents attended high school, but they were committed to sending their 4 sons to college, and they both worked tirelessly towards that goal. So let me tell you a little bit more about their lives and how they inspired me to create the Kominsky Fellowship. Let me start with my mother. Here's a photo of my mother in the summer of 1936, during the depths of the Great Depression, and 7 years before she got married. She is 13 in this picture. Despite the smiling faces, these girls are not at summer camp. They are working in the cornfields of Pennsylvania. My mother stopped going to school after 6th grade, so in this picture, she is already finished with her education. To help support the family, she worked in the fields along with her family during the summer, and then cleaned houses and babysat during the rest of the year when they returned to the city. When she turned 16, she said that she was 18 to get a job in a meatpacking plant. And 2 years later, around the time that she got married, she got a job working for one of the tin can manufacturing companies that were prominent in Baltimore during that period. That job was a union job, and because it paid well and provided good benefits, my parents were able to emerge from the poverty of the Great Depression and build a blue-collar, middle-class life in the suburbs of Baltimore after they were married. My mother was the only woman in our extended family to work regularly outside the home, and as all working mothers know, that meant she had 2 full-time jobs. And for those who've been staring at this photograph and wondering which girl is my mother, there she is. My mother still lives in Baltimore and has been in a continuous care retirement community since my father died 20 years ago. She will be 99 in 2 weeks. Wow. This is a picture of her from 2 years ago when she was still relatively ambulatory. Now she is essentially bedridden. Her biggest regret these days is that she can no longer take care of herself, because as she tells us every time we visit, and we were there 2 weeks ago, she never wanted to be a burden on anyone. She's also still very proud of her son who became a professor. And I'm grateful that she worked so hard to make it possible. Like most parents, mine wanted their children to have a better life. And that's what they worked so hard to provide. But it was my father who instilled in us from a very early age that college was the pathway to that better life. My father stopped school after 9th grade. Like my mother, he also worked for a union. He worked on the waterfront as a longshoreman and then as a carpenter in later years. International Longshoremen Association union member. In those days, they worked in teams called gangs, and my father and my 2 uncles were gang leaders. Slightly different meaning but this is my father's gang. And for those who are guessing, that's my father. A few years ago, my mother asked me if my father ever took me to work with him. And I told her, of course, Mom. I knew even then that the goal of Take Your Son to Work Day was to show me my options if I didn't want to go to college. But what my parents didn't realize is that they didn't need to scare me straight. I knew very early on that college was the best path for me. And some of the stories my father told me about working around the waterfront made me both worry about his safety and helped me understand why he always projected such a tough guy image. It was not an easy job. So here I am today, 49 years after graduating from high school, 44 years after graduating from college, 37 years since getting my PhD, grateful for the opportunities and support provided to me by so many people along the way. And the tribute video, when it's available, will pay tribute to all of those people. Now, as I was planning my retirement, I asked myself, how can I continue to pay forward long into the future the great legacy my parents left me? The answer was to create a permanent endowed fellowship to provide funding for first-generation college graduates to attend UCLA and study health policy at the Fielding School of Public Health. Laurie and I endowed the Kominsky Fellowship in 2020 to provide up to 2 years of support to one entering MPH student every year for the indefinite future. The first award was made at the beginning of this academic year. However, to increase the value of the endowment, in addition to our original gift, I have been doing targeted fundraising for the past 18 months. And I'm proud to report that I've been able to raise almost $50,000 from colleagues, friends, family, former students and classmates, and even childhood friends who knew me when. I plan to continue my fundraising efforts into the future, although I promise I will not solicit from you twice once you've made a donation, unless you give me permission to do so. Having said that, I'm happy to say that the list of donors who've made multiple gifts is growing. And thank you again to all of you here tonight who've already made a contribution to date. Finally, I'm also proud to announce tonight that Laurie and I have made provisions to double our initial investment in the fellowship as part of our estate plan. This is the best way I can think of to honor my parents and to help support the next generation of health policy leaders. Thank you, that was the hard part. It's always risky talking about my parents in public. So, transitioning now to the substantive portion of tonight's program, I'm pleased to be joined tonight by two distinguished colleagues, Professor Arturo Bustamante and Professor Mark Peterson, to discuss current health policy efforts at the federal and state level with a focus on issues related to coverage, eligibility, and affordability. Before hearing their perspective, let me spend the remainder of my time setting the stage for tonight's program by identifying and very briefly discussing what I view as the most important policy issues currently at the federal level and in California. I also would like to share some results from two just released policy briefs published in collaboration with our colleagues from the Berkeley Labor Center, using the latest findings from our CalSIM model of California's health insurance markets. First, the Build Back Better Act. This appears hopelessly stalled in the Senate. If passed, it would permanently extend the American Recovery Plan reductions in out-of-pocket premium spending and the extension of ACA subsidies to those above 400% of the federal poverty level. Mark will speak more about this bill, and I will present our estimates of the impacts in California if the ARP subsidies elapse. Likewise, Medicare expanded eligibility and benefits, which were part of the Biden campaign, appear to be going nowhere. Mark will have additional perspective on this as well. The No Surprises Act went into effect in January and is intended to protect patients from surprise bills under three specific circumstances, namely when an enrollee first, or number one, receives emergency care at an out-of-network facility or from an out-of-network provider. 2, requires emergency air ambulance transportation. Or 3, receives elective non-emergency care at an in-network facility, but is treated by an out-of-network healthcare provider. I'd say that over the last 20 years, this issue has generated some of the most frequent requests for commentary that I've received from the media. So federal legislation is long overdue, and this is a problem that has long needed to be addressed. Next, according to a recent Kaiser Family Foundation study released last month, medical debt continues to be a major issue for millions of Americans, despite gains in insurance coverage. High deductible plans appear to be the major cause, with a significant portion of privately insured households reporting less than $2,000 in liquid assets. Unfortunately, the No Surprises Act is unlikely to have a noticeable impact on this issue, according to the Kaiser study. Under the public health emergency in effect since March of 2020, CMS has required states to suspend redeterminations and maintain continuous enrollment of Medi-Cal or Medicaid recipients. I'm sorry, I lost my slide here. The suspended redeterminations have resulted in an increase of about 19.1 million beneficiaries, and as a result, there are now about 85 million Americans who are eligible for Medicaid. Based on another recent Kaiser Family Foundation survey, an estimated 13% of beneficiaries are likely to lose their coverage when the emergency ends and states start resuming their redeterminations. So this is a major cliff that we're facing in terms of the Medicaid program. Finally, the family glitch refers to the fact that the income threshold for determining if people with employment-based insurance have an affordable offer from their employer is based solely on the cost of individual coverage. The Biden administration has recently issued a proposed rule to fix this problem. In other words, it doesn't need congressional action. This is something that can be fixed through the rulemaking process, which should improve the affordability of coverage for an estimated 5.1 million Americans, including 450,000 currently uninsured. This, too, is a problem that could have been and should have been fixed years ago. Arturo will be speaking later in more detail about the distributional impacts of the ACA and the ongoing challenges in achieving affordable and equitable coverage. So turning now to significant California health policy initiatives, in the interest of time, I'm going to very quickly highlight some of the most significant health policy developments in California. The most significant development, in my opinion, is the current and proposed expansions of Medi-Cal eligibility to all undocumented Californians. I'll be presenting data in a minute on the expected impacts of these important expansions. Also, as a reminder, California started providing enhanced subsidies to increase the affordability of covered California premiums in 2020, although these subsidies were superseded by the American Recovery Plan. I'll also present data on the impact of these subsidies in a minute. In March, the Healthy California for All Commission issued a draft report on key design features of 2 options for financing, for unified financing in California. One based on direct payments from the state, namely a single payer system, and the other based on regulation of health plans offering the same standard benefit package. This is a topic that probably merits its own Torrens forum session in the future. So there's a lot to discuss, but I'll be interested to see what questions we have during the Q&A. All right, something's glitchy here. The next bullet is supposed to be the AB 1400. As I expect everybody in the audience knows, AB 1400, the latest single-payer bill in California, stalled in the legislature in January and didn't even come to a vote despite the Democratic supermajority in the Assembly and the Senate. And I expect that more than a few people have questions about this as well. The proposed Office of Healthcare Affordability would be an important step in measuring and monitoring healthcare spending in the state by establishing spending growth targets and developing recommendations for improving affordability. A bill to create this office was passed by the Assembly in 2021, but so far has not advanced in the Senate. There it is. So one initiative related to healthcare spending and affordability that is moving forward is the creation of an all-payer claims database. Everyone who's tried to conduct research on actual healthcare payments rather than billed charges knows that this type of database is essential in understanding actual expenditures for services and how those expenditures vary by insurer, location, provider, and other important dimensions. APCDs are essential for creating real price transparency in the healthcare markets. This is also an initiative that's long overdue in California and is finally going to become a reality. Finally, Covered California published a policy brief earlier this year outlining options for eliminating deductibles from Covered California if federal funding is permanently available either through the Build Back Better Act, which is stalled, or a renewal of ARP subsidies. In light of my previous comments on medical debt, this is obviously a step in the right direction, although it does not address the continued growth of high deductible plans in the employer-based market. So finally, I need to wrap up my comments with 4 quick slides. This slide just emphasizes that the expansion of Medi-Cal to undocumented adults ages 26 to 49 would result in the largest reduction in uninsured Californians since the original enactment of the ACA. But despite all the progress of expanding coverage in the state during the past decade, we still project that 7.1% of non-seniors would be uninsured in 2024. Historical low, but still 7%. Second, this slide shows how the expansion of Medi-Cal to undocumented adults ages 26 to 49 would compare to other expansions of since 2013. And it is just much larger than all the other expansions that we've done to date. This is a vulnerable population. This is largely a working, uninsured population that deserves health care benefits. Third, this slide shows some of the distributional impacts of the proposed Medi-Cal expansion to undocumented adults, ages 26 to 49. 2 findings are worth noting. First, California has already achieved substantial racial and ethnic equity in coverage, although Latinos would still face the highest rates of uninsurance even after this expansion, roughly double that of other populations. Second, Opening Medi-Cal to all undocumented age groups still leaves a substantial portion of this population uninsured, largely because of the absence of ACA subsidies for the undocumented. Finally, in closing, if ARP subsidies expire, we estimate that 230,000 Californians will lose their health insurance next year, simply because of affordability problems. So in closing, I'd just like to conclude that the past decade has seen significant progress in expanding coverage and affordability for millions of Americans and Californians, but needless to say, significant challenges remain. So it's now my pleasure to turn the podium over to Professor Arturo Bustamante.
Good night, everyone. I'm really honored to be here today to celebrate Professor Kominsky's outstanding academic career and to discuss the achievements of the ACA and its pending tasks in terms of healthcare equity. Since Professor Kominsky has already provided a perspective for California, my presentation today will be focusing on national trends and data. Also, since healthcare equity can be measured in many different ways, I will focus my presentation on health coverage among race and ethnic minorities and immigrants. But first, I want to continue the celebration by congratulating Professor Kominsky for his outstanding academic career in health services and health policy research. I feel very lucky to have had the opportunity to work with him and to learn from Jerry's impressive trajectory. He's definitely one of my role models at UCLA. I still recall the first time that I met him as I was interviewing at UCLA. Jerry offered me a very honest description of what the job will entail and what were the research and teaching expectations. Over the years, as I developed as a scholar, I often recall that first conversation because everything that he told me was quite accurate and very useful. After I joined UCLA, Jerry always made me feel welcomed and served as one of my mentors. When I contributed to the latest version of the departmental textbook that Professor Kominsky edited and that is shown in this slide, I got to admire his sharp understanding of the US healthcare system and his nuanced knowledge of state and federal health policy. This textbook also became the main teaching material in my classes that I used to introduce hundreds of graduate students who have been trained in our department to understand the US healthcare system. I hope that we will continue to see Jerry around, even if on a part-time basis, but I'm sure that he will continue to inspire future generations of students and faculty in health policy and management. So now, let's shift our attention to a health policy that has been central in Jerry's academic trajectory, the Affordable Care Act, or better known as the ACA. This is one of the landmark healthcare legislations in the history of the country. It has been almost 12 years since the passage of the ACA, and from my perspective, the most important accomplishments of the ACA in terms of healthcare equity are the substantial reduction in the number of uninsured individuals and improved access to healthcare, particularly among those who are low income and people of color. Very important as well was that the ACA changed incentives in the private health insurance marketplace by not allowing insurers to set exclusions for pre-existing conditions or set lifetime limits. And if we add to this the marketplace subsidies, the Medicaid expansion, and the ACA's dependent coverage provision, all these health policies have improved the financial protection of low and middle income families. And as I will show in the following slides, the ACA has also contributed to closing some gaps in healthcare inequities. In 2010, after the passage of the Affordable Care Act, people of color were more likely to be uninsured compared to their white counterparts. After the full implementation of the ACA in 2014, there was a rapid decline in the number of uninsured adults, particularly among people of color and low income. In this chart, you can see how the most pronounced drops in the share of uninsured adults happened between 2014 and 2016. Starting in 2017, however, uninsured rates flattened and increased slightly for Latinos, Black, and white individuals. This chart also shows very clearly that while health coverage disparities between people of color and white individuals remain in place, the ACA has contributed to an overall reduction in the magnitude of these disparities. Another way of understanding the coverage gains under the ACA is in access to healthcare, particularly among newly insured individuals. According to this chart, in 2013, a year before the main provisions of the ACA were implemented, Black and Latino adults reported significantly higher rates of cost-related problems getting healthcare. After the ACA, major coverage gains expansion in 2014, Black and Latino adults continued to be more likely to avoid care due to healthcare costs. However, the gaps compared to the white population narrowed. I also want to point out that, as in the previous chart, most of the improvements happened between 2013 and 2016. Another variable used in health policy and management to measure access to care is having a usual source of care. And this is defined as having a personal physician or other type of healthcare provider. And in this chart, we can see that after the ACA's major expansion in 2014, Latino and Black adults experienced the largest overall improvement in reporting a usual source of care. Although again, most gains happened between 2014 and 2016. Some of the inequities shown in the previous three charts could be attributed to differences in socioeconomic and demographic factors across race and ethnic groups. However, in a recent research piece, my colleagues and I controlled for differences in socioeconomic and demographic factors among people of color, and we reached very similar conclusions, that Black and Latino adults have gained in health insurance coverage and access to care, and overall differences with their white counterparts have narrowed since the implementation of the ACA. One of the key limitations that I want to highlight about the ACA in terms of healthcare equity is its eligibility criteria. Certain race and ethnic populations, such as Latino, Asian, and Black adults, are less likely to be eligible for the ACA compared to their white counterparts. As shown in this chart, almost 70% of white adults are eligible for ACA coverage. By contrast, only 53% of Latino adults, 60% of Asian adults, and 67% of Black adults are eligible for ACA coverage. And the main reason why Latino and Asian adults are ineligible for ACA coverage is immigration status. From my perspective, one of the main limitations of the ACA was the exclusion of undocumented immigrants from all ACA programs. Legal status is a key factor to understand the role of the ACA on eligibility among immigrants. As shown in this chart, documented immigrants have similar eligibility for the programs and subsidies of the ACA, almost comparable to US citizens. However, undocumented immigrants are ineligible. The lack of ACA eligibility among undocumented immigrants has contributed to a substantially higher share of uninsured individuals, particularly among people of color and low-income adults. As you can see in this chart, while 8% of US citizens were uninsured in 2021, approximately 26% of documented immigrants and 42% of undocumented immigrants were uninsured. Only a handful of states, among them California, have created local programs to extend some form of health coverage for the undocumented immigrant population. However, this is certainly an area where the ACA could be improved in terms of healthcare equity. Another area where the ACA can contribute to improve healthcare equity in the foreseeable future is the Medicaid expansion. As mentioned before, one of the key policies that the ACA implemented to expand health insurance coverage was a Medicaid expansion to adults whose income was under 138% of the federal poverty level. Unfortunately, the Supreme Court ruled that the Medicaid expansion was voluntary for states and turned it into a big political battle. Not all states have expanded Medicaid, and disparities between those states that have expanded Medicaid and those that have not are large and widening. As you can see in this chart, with data from the 2020 census, the uninsured rate among those adults whose income is under 100% of federal poverty level is more than double that from states that have not expanded Medicaid. To conclude, I want to make the case that for the ACA to continue closing the coverage gap, it would be necessary to expand Medicaid to those states that have not yet expanded. Currently, 39 states, including the DC, have expanded Medicaid. However, some large states with a high concentration of people of color and immigrants, such as Texas, Florida, and Georgia, have not yet expanded Medicaid. So there is still room for the ACA to continue closing disparities in health coverage and access to care among people of color and immigrants, if a favorable political consensus could be reached. But I'm sure that Professor Mark Peterson will tell us a little bit more about it, about the politics of the ACA. With this, I conclude my presentation, and I look forward to continuing the conversation during the Q&A. Again, congratulations, Jerry, and thank you very much.
Hello, everyone, and hello, Jerry. Thank you so much for this event and for allowing me to be part of it. To give you a sense of how honored I am to be here, this is the first time in 3 years I've put on a tie. And it's about as far as I'm going to go in any exercise of those terms. I'm going to play the role here of talking about the politics of health policy, which is never really a pleasant thing to do in the United States. And what I'm going to talk about is what comes next, because the ACA is here to stay. That is a very pleasant thing to say. And the question is, will it take another 100 years to get to the next round? And why is it so hard to do healthcare reform in the United States? So a quick dash through these issues. Jerry and Arturo have really talked about what the ACA has accomplished and also what it has not accomplished, what remains to be done. Coming out of the 2020 presidential nomination process for the Democrats, we really got the two pathways that could go forward. One was Joe Biden's Protect and Build on the Affordable Care Act, and the other, of course, is Bernie Sanders' Medicare for All. Both of these things are very hard to do, and it turns out they're going to be quite hard. This was, as Jerry alluded to, this was President Biden's agenda coming out of the campaign. I'm not going to go through all the verbiage here. The important things are highlighted in red, and as Jerry reported, some of them have been captured in the American Recovery Plan Act, but they're about to disappear, and they probably will disappear. Not all of this made it even into the Build Back Better Act in its original form. They're not in there in its shrunken form, and our guess right now is the Build Back Better Act is not going to be enacted, at least with a lot of the health provisions, but maybe we'll get to regulatory advance on the family glitch. So a lot that was proposed, typical Democratic approach of pushing the little envelopes over here and over there and over there, as opposed to the clean sweep, because this is thought to have more political legs, but it's difficult. It would have made a big difference if all this happened. It would have brought us closer to universal coverage, but we're still going to be quite distant. Now, let me, as a political scientist, as a presidential scholar, talk a little bit about political capital. When presidents get elected, we look to see what kinds of political firepower they bring into office with them. Things like, do they have anything representing a mandate out of the election, the popular vote, the electoral college vote? Where is the public in their support of the president, both coming into office and at times of policy choice? What kinds of gains or losses were there in the Congress for the president's party? How many seats do they have? And I have something here called solid votes. Those are the reliable votes among Democrats based on unity within the party. And just to point out, 2009-2010 was the best context for healthcare reform in the United States history. And I have a big book to explain why that is the case, which I won't go into deeply. But even with that, notice that the Affordable Care Act passed in the House 219 to 212, below what would have been the reliable Democratic vote even. Very tough, very close. In the Senate, it passed because for a few months, the Democrats actually had 60 votes to overcome filibuster. That disappeared when Scott Brown took Ted Kennedy's seat in Massachusetts, surprisingly, on January 19th special election in 2010. Now, next. I'm not going to go through all the numbers, but that red and the double digits tell you that Joe Biden came into office not with those circumstances. It would have been very difficult to do anything, as he has discovered, and the Democrats have discovered, simply because the political capital really is not there to move. And of course, he wanted to do legislation across a number of policy domains, so very difficult task to move forward. It's worse now. The president's numbers have really dropped. We are expecting that the Republicans will take the House, maybe the Senate. This is just a very difficult political circumstance, so I don't think we're going to be meeting a couple of years from now and talking about the passage of the public option or certainly Medicare for all. One of the issues about any kind of big public sector initiative is does the public trust the government in general? This is from the Pew Research Center, and this is a long-standing question. Do you trust the federal government to do the right thing almost all the time, almost always, most of the time, some of the time or not at all? And what you see when Medicare passed in 1965, 2/3 of the public trusted the government to do the right thing almost all the time or most of the time. We are down now to 24%. And even Democrats are only at 36%. So there's just a profound sense that we don't really trust this fundamental set of institutions to move forward in the ways that we'd like them to move forward. Now, we also traditionally ask questions like, does the public support the idea of the federal government doing more to help provide health insurance for more Americans? The numbers have always been quite strong, but here's the important distinction now. Democrats, 9 out of 10, have consistently said, yes, this is a role for government. Republicans used to, and they don't any longer. A huge drop in Republican support for the very idea of the government doing things to expand health insurance coverage. If you ask, is the federal government's responsibility to make sure all Americans have health insurance? Again, you see this very deep divide where Republicans say no, overwhelming majority, Democrats say yes. It's very hard to reach for any kind of universal program when all those folks are part of what universal means. Now, there's some encouraging numbers, it would seem to be. When Americans on Kaiser Family Foundation are asked whether they support Medicare for all, universal coverage, these terms, national health plan, it looks like there may be some positives there, but again, the parties are completely split on this among the voters, almost a 50-point difference consistently. All right, well, let's make that go away for a moment. Let's just focus on the total numbers. That looks good. 6 out of 10 Americans support Medicare for all or national universal coverage or a national health plan. So why can't we move on this thing? Well, the next question is, what do they mean? What are people responding to when they have these polls asking this question? And here things get problematic. For instance, in the center here, among those who favor a national health insurance plan or Medicare for all, 2/3 think that they'll be able to keep the current insurance, private insurance. That's kind of a contradiction. When people are asked, would you favor or oppose a national Medicare for all plan if you heard that it would do each of the following? Let me just pick out 3 here. Threaten the current Medicare program. Anything that makes a change in the current Medicare program is a threat. Require most Americans to pay more taxes. I kind of think so. Or eliminate private health insurance companies. 6 out of 10 say, we don't want private health insurance companies eliminated. So even when we get some positive numbers, when we dig deeper, there's softness there that we have to worry about. Now, in a survey that I did with Darren DeWitt through the Cooperative Congressional Election Study in 2020, we also did this in 2018, we decided to ask, let's ask without labels, because people read into those labels. Let's just ask 3 descriptions of the healthcare system that you might want to have unrestrained by any political considerations, just ideal types. And so we had a descriptor of what would be a single-payer system, tax finance, comprehensive care, no co-pays, da-da-da. At the other end, a fully or close to fully private system where people bought insurance if they wanted it, they could buy whatever amount they wanted, and the only role for government would be to ensure that the most vulnerable and the poorest had some access to care. And then the center is always some version of the current system. These are the data. First thing you notice is, as usual, no one wants the current system. That's pretty clear. But then the problem is the parties, again, are deeply divided. Supermajority of the Democrats in the voting public want to have something that resembles single payer. A majority of Republicans want to have the complete opposite, something that resembles a close to fully private system. And moreover, neither gets majority support among all the voters. At least the Medicare for, or the kind of single payer version gets close to the 50% margin, but still falls short. So it's hard to imagine, again, how you put together a coalition that would favor change. Even more complicated is when you actually look at what the nature of voters are within both parties. They're spread all over the ideological map. This is Lee Drutman's work. It's based on 2016 vote. Blue is Clinton, red is Trump, and yellow is for the third-party candidates. The left-right is an economic liberal to conservative scale about taxation, government intervention. The vertical scale has to do with social issues, whether or not the government should allow abortion or forbid abortion, support LGBTQ rights or not, and on down the line. And what we really see with that diagonal line is the parties are split across these two dimensions, and it's really a party of economic solidarity on the Democratic side versus a party of traditional culture on the other side. And some have argued, and with data to support, that it's really a Republican Party that is focused very much on traditional white male heterosexual orientations. It's very hard to imagine how you build a coalition across these domains for reform. Now, another way to look at this is Lee Drutman again. What if you asked people a set of questions about what party they would choose if we had a multi-party system? And what he identifies are 6 possible parties based on the responses. And the party that would be behind universal coverage, the Progressive Party, is there, but it's only one of 3 Democratic parties, 2 of which are either more establishment-oriented, more business-oriented, or more prone to being captured by the culture wars, the social conservatism that's often in many of the political debates. So that's the overall picture. What about California? We're different. We're blue. We are progressive. Why can't we just do AB 1400 in California? Quick set of reasons. We have ideological dispersion in California, too. We have Democrats in the legislature among voters who are business-oriented and not all in favor of a big government program. We are a blue state, but I don't think most people realize this. There were more Trump voters in California in 2020 than the individual populations of 27 states in the United States. Imagine trying to go through that argument in the state, even though we are heavily Democratic. Much better trust in government in California than national level, but among Democrats. Not independents, not Republicans. And I see from time to time the bullet train analogy. The state can't even figure out how to build a bullet train. You're going to turn over the healthcare system to the state. Don't do that. In any domain, there's the existential interests of current stakeholders. I turn to the distinguished late health economist Uwe Reinhardt, who said it in simple terms. Every dollar of healthcare expenditures is someone's healthcare income. And they are going to defend that to the death. And certainly when we talk about doing things that would really curtail private insurance. Medicare. Medicare is about 20% of healthcare spending. There is no waiver with Medicare. California can't go to the Department of Health and Human Services and say, give us a waiver for the Medicare funds. Doesn't exist. Congress has to act. That's not going to happen. And even if it did, I can tell you at that moment the Medicare beneficiaries in the current program would not want to, going to be highly resistant to that. Finally, the Employee Retirement Income Security Act, ERISA of 1974, it stipulates, as you know, that employers who self-insure cannot be regulated by the states. In California, about 14% of Californians are in self-insured employer-sponsored plans. It means the state cannot compel them or their employers to move into a single-payer system. All they can do is entice the move. These are a lot of significant barriers to try to, and by the way, I am a single-payer supporter. I would be an advocate for that. It's just my job to point out how difficult it is to do. So, Jerry, you know, we get it. We get why retirement was so enticing. Playing golf on the Hawaiian Islands. Next time, I'm sure you'll invite all of us to join you on the links. But I do have one request, and that is we can't lose you. You've been too important, too influential in informing and educating policymakers, the media, the public. So during at least a couple of those swings, can't you take a shot down the center of the fairway for universal coverage and keep us in the game? Thank you very much.
Thank you, Mark. That was quite a nice swing there. Where did you get that photo?
I have my sources.
I know. So before we open it up to Q&A from the audience, let me just take this opportunity to ask Arturo and Mark one question each. And Arturo, I'll start with you. So one of the things that I thought was impressive about your presentation and the data, and one concern that I've always had in terms of evaluating the impact of the ACA, is this difference between absolute versus relative improvement in health insurance status or other health outcomes. And it's quite clear that we've seen tremendous absolute reductions in things like uninsurance rates. But when we look at where we are today in 2020, or even in 2019, which is I think where your data leave off, there's still relative differences across racial and ethnic groups that, if you actually look at the numbers, seem to have widened, even though we see these graphs look like they're getting closer together. The relative difference between them is actually greater than 10 years ago. So what do you think we should be focusing on, and how do we communicate the fact that even though everybody's better off than they were, most groups are better off, that what we're really striving for is equity across those groups and the outcomes, not just everybody getting a little bit better?
Right, I agree. I think that, and we have seen that in many different studies that happened after that first releases of data in the 2014 implementation of the Affordable Care Act. Many of the expected changes in access to healthcare were not seen immediately. Sometimes even like the evidence from the Oregon experiment showed that people were not shifting towards preventive healthcare, but they were still using the emergency room to access healthcare. So I think that these are some of the changes that have created inquiries among the research community. Why these type of changes have not happened, even though we expected them to happen after the implementation of the ACA, and all these improvements in access to healthcare due to insurance. And I think they're having like three different factors that can be mentioned. Number one is, well, the ACA has been kind of like a learning policy. Many of the first plans, even like its release was originally kind of complex when it was originally launched by the Obama administration. But it has been kind of like, well, let's see if this type of policy is going to work. And I think it has been improving, especially in the type of subsidies that have been implemented through the Affordable Care Act. So I think that the first one is the implementation, like a complexity and the uncertainty in the type of expected outcomes from policymakers when they first designed the ACA. The second one, I think, it's the fact that the healthcare system continues to be under certain type of incentives by the original fee-for-service type of model that we were trained to before the ACA. So that has created like things like narrow networks, for example, for Medi-Cal or Medicaid enrollees. And it has also made difficult for a lot of the pilot programs that were related to the ACA to be successful and to find evidence that those programs were going to be changing the way that the healthcare system operates. So those old inertias from the old fee-for-service system, I think that has made more difficult for the ACA to accomplish the improvements in access to care that we expected. And the third, I think, is also the social determinants of health. Many of the challenges that the newly insured population faced made it more difficult for them to use healthcare. No? There's a high opportunity cost. There's not the population who have been without insurance for many years. they need to be socialized into knowing how to access the healthcare system, how to make an appointment with a primary care provider. That many times getting to the doctor is going to be only 15 minutes, and then they will have to go out. So this type of like learning of how to use the healthcare system among the uninsured and newly insured population is also, I think, an important challenge that we need to be aware. And I think can also explain part of what we have observed in this more than a decade of ACA implementation.
Yes, and it's very clear, I think, that we've learned now from 10 years of research that health insurance coverage is a necessary but not sufficient condition for true equitable access to healthcare and utilization. So, thank you. Mark, great presentation. Your data, I think one of the key takeaways from your presentation for me, and by the way, I'm really glad that you used the Pew slide. I discovered that slide about 5 or 6 years ago, and I can't tell you how grateful I was to learn that they've been conducting this survey for now almost, 70 years, since the late 50s. Because I've been telling a whole generation of students that things were different when we were growing up. We lived in a different world where government was not the enemy, and where we actually saw, particularly the federal government, as a potential agent for positive change in American society. And that data from the Pew Foundation shows very, very clearly how that eroded in our, not only in our lifetime, but by the time I got to we started college, it was gone. Watergate, Vietnam, assassinations.
Yep.
It was, trust in government was gone, and we have never gotten it back. My question, though, to you, as opposed to my commentary, is that it seems to me that the data that you're presenting suggests that what we really seem to value as a society, and this is true for Democrats as well as Republicans, it seems, is some choice in our healthcare system, and that it is the lack of choice that seems to evoke a visceral sort of reaction to government intervention in the marketplace. And what's your reaction to my assessment of your presentation?
Well, a couple of things. I think people do want choice. There's always a debate in the reform community among those who are single-payer advocates. They say, yes, people want a choice. They want a choice over a physician. They want a choice over their pharmaceuticals. They want a choice over hospitals. They want a choice over where they may go for diagnostics. They don't really want a choice over health insurance. And people are not in love with private health insurance. The main issue there, many argue, is that people are afraid of what comes next. They know what they have in hand, but they're afraid of what it would be replacing it. And very often there's a strong sense that Americans in general, very large numbers of percentages of Americans, want everybody to have access to health care. And they don't want finances to be a barrier to that. But to quote from Bob Blendon at Harvard, who's done a lot of work for many years on public opinion research, he goes to the old adage about the Hippocratic Oath, first do me no harm. I don't want to put my life and my family's lives on a potential risky scenario in order to provide that access for everybody. So it's less about what I really want to be able to do is choose Anthem. I mean, come on. That's not what people are really interested in. They're really interested in having the security. They're interested in having choice. They're worried, perhaps, the government will deny them choices of medical treatment, so there'll be rationing. And we ration on finances now, but people are worried about there'll be rationing in other terms. So I'd be very careful about what we really mean when people say they like choice. What they are is afraid. And this is why every national healthcare reform plan, other than Bernie Sanders and Elizabeth Warren and Pramila Jayapal on Medicare for all have avoided doing anything to the Medicare program. Clinton's Health Security Act would have not changed the Medicare program. Affordable Care Act only provided some additional benefits in the Medicare program. Why? You don't want to go there. Let me get you another little vignette. When I was working in the early 1990s for Senator Tom Daschle, we did a big comprehensive healthcare reform bill, which was essentially a single-payer bill with opportunities for some management through private plans. our legislative director went to meet with veterans because Daschle had a very close relationship with the major veterans organizations. He did a lot for vets. So they were friends. I mean, this was a real buddy-buddy relationship. And when the legislative director went to them to explain our healthcare plan, she came back kind of shocked because they were very antagonistic. Why were they antagonistic? Because they had put their lives on the line to earn access to medical care, to universal coverage for them. And the idea that any Joe Schmo on the street could get universal coverage, get free access to health care, just struck them as unfair given what they had committed to get that benefit. So that's one population. Then you have the Medicare population that's going to be very concerned about giving up what it has. Medicare is more popular than anything. It's one, the third rail of politics. It's you touch it and you die. You just really avoid it all you can. And so that's why it gets to be so complicated to put all these pieces together.
And I would add to that a number of people who have employment-based insurance feel the same way, that they are more or less happy, maybe not as happy as with Medicare,
Right.
but that the idea of losing that insurance is a threat.
May I throw one thing else out on the table, which I always should mention? It's a little hard to do in a short period of time, but gets to this as well, which is when we talk about choice and people wanting their fellow residents of the United States to have some kind of access, there is the big gorilla in the room, and that's race. Time and again, I have the data from our surveys, a lot of other people have the data as well. Support for government intervention on healthcare is highly explained by party, highly explained by ideology, and independently, controlling for party and ideology, independently explained by racial intolerance. And when Barack Obama became the face behind many of the provisions in the ACA, which had been previously popular among a lot of people, their support for government intervention went down because of race. And that's something in this country we face uniquely, and it's just going to be, and that's part of what we're seeing in the results.
Exactly. Thank you for reminding us of that. So we have time for questions from the audience now. Thank you very much for your presentations. And we do have microphones circulating. So I see a hand over here. I recognize my colleague.
Yes.
We've got a mic coming.
The impact of the ACA.
Could you identify yourself for the audience,
My name
please?
is Debbie Freund, and I'm a good friend of Jerry's and many of the people here, and I'm extremely proud of him. And I have been a donor to his scholarship fund. And thank you for doing that. And more will come.
Debbie is also President Emerita of Claremont College.
As all of your PowerPoint pictures showed, there's been tremendous increases in coverage from the ACA and all of the provisions, and a real decrease in people who are uninsured, even though there are tremendous numbers who are, and hopefully in the state will really get the immigration issue done. But we haven't achieved equity in health outcomes. And there's new data on racial concordance, which shows that people who choose to go or feel more comfortable going to a physician or provider who speaks their language, looks like them, brings better health outcomes. What is the point of having access if we don't get there so that all people are equally healthy? And what would you say are the first three things we should do about that?
Sure, well, that's a tough question, but I can say probably a couple of things first. So I think that you're right. Access to culturally competent providers is an issue that has been discussed for many years in the state, in the nation. And then you're right as well that the latest research shows that having access to healthcare doesn't necessarily mean that you're going to have better health outcomes. No? So I think that in that case, we know that the healthcare system doesn't necessarily is like the main force that will help us achieve that health equity that we need. There are other social determinants of health, like a residential segregation, socioeconomic status, unemployment, that will help us close those gaps.
Arturo, what do we tackle first? And what do you think would make the biggest difference?
Well,
I think we all know about those.
Yeah, so I think that I think that we can think about things at the short and the longer term. In the short term, I think that what Jerry mentioned about the expansion of medical to the undocumented is an important first step. We have an older immigrant population that will need to get a substantial health care, and that pretty much remains ineligible for Medicare. So that's a positive first step. But in the longer term, we need to definitely have awareness of what are the most important interventions that will help us close those gaps. And one of them is going back to what you mentioned, having access to those providers who the people trust the most, or with whom they can communicate better. So I think that we need to take advantage of what we have learned so far during COVID, for example, telehealth. At the beginning, a lot of these populations were totally against the idea of telehealth. And I talked to them in my focus groups, my research projects. They didn't like telehealth. But as they got used to having conversations with their providers through video or phone, they have, many of them have changed their minds. And now they find it more practical to do that type of contact with the healthcare system. I think this type of policy has tremendous potential to precisely help those individuals access the providers that they want to access. So helping the U.S. healthcare system to react faster to that type of changes in preferences is what I think we should do as well, especially from the health policy and research community. Tell them, well, this is how demand is changing. So now we need to shift into that direction.
Mark.
Yeah, we have a lot of evidence now, and a former student of mine who's now getting a PhD in political science at UCLA has her own firm that she's been working with the California Healthcare Foundation, looking at blacks in California. And very intensive study and really a remarkable and stunning amount of data that's supported in other research of the different experience that blacks have going into the medical system than whites have. Feeling overt racism, feeling not understood, feeling being taken for granted, feeling that there's not the expectations that they're not going to be able to be as good a patient as a white patient. All the things that Arturo just mentioned are extremely important, but we also have to change what's happening internally within our own institutions, our medical schools, our whole training process and recruitment process, not only to bring in a more diverse population of physicians, but to train the physicians who are there to be much more self-aware about how practice happens when dealing with different kinds of people coming in to get medical care. And that it's just shocking, the extent to which highly educated people in this country are still engaging in behaviors that others are interpreting as being explicitly racist, or at least completely blind and ignorant to these processes. So we are sitting in the Ronald Reagan Medical Center and across the street effectively from the UCLA David Geffen School of Medicine. That's a place to begin along with all the other major educational institutions in the country.
Thank you. Other questions? I see someone's hand in the back here.
Hi. Can you guys hear me? Oh, okay, there.
Please identify yourself for us.
So my name is Kara Brushweiler. I'm a student nurse at Azusa Pacific University. And I first just wanted to thank the three of you for sharing with us, and specifically you, Jerry. I think it's really refreshing to see somebody so successful yet so humble, be in the place that you are. It's just very encouraging and also humbling just to see someone like you using your platform in such a humble and gracious way. So this is kind of a loaded question, and I'm sure we could spend hours talking about it. But Mark, you talked about how politics and, the parties are so polarized on this issue of healthcare for everyone. So I'm interested to know what you guys might think some maybe baby steps that could be taken to sort of overcome this barrier of polarization, so that we can at least take some small steps towards healthcare for everyone. I know that's like a really huge loaded prompt, but I'm just curious how you guys think a place we could start to overcome this barrier of having political parties that are so opposite to each other.
The political expert.
Well, look at the time. It's a wonderful question, and it's a great question. And I have to preface my remarks with saying it's even worse than what I presented, in that we have a tremendous amount of data now from a lot of political scientists that the growing partisan polarization that's happened really starting in the early 1980s on to today is not only more intense, but it has reached what is referred to often as negative polarization. And by that, it means that people in each party think the members of the other party are a threat to the country. Mm-hmm. That's different from a policy difference that I put up. That's really a sense that if the other side takes control of the institutions of government, it is a threat to the country. And frankly, we have a political party right now which is not showing any great interest in preserving the institutions of American democracy. And that's very worrisome as well. So how do you break through that? I think if people had the magic bullet on that, they'd be working in the Biden administration right now, and they'd be working with cross aisles in Congress trying to figure that out. One of the things to note, and this is where it also gets frustrating, but where there may be an avenue for advancement, is when the Trump administration and the Republicans in Congress in 2017 were trying to repeal and replace the Affordable Care Act, there's pretty good evidence that a huge number of the people who were benefiting from the Affordable Care Act, including dramatically in states like West Virginia that went hugely for Donald Trump in 2016 and 2020, that they would have been very badly hurt had the ACA been repealed. Mm-hmm. Millions of them would have lost their health care coverage. They would have lost other kinds of protections. And they are precisely in that income band that does well with the Medicaid expansion or does well with the subsidies in the marketplaces, the exchanges. So if you can get those people to really appreciate what they are getting and to know what's responsible for that and how it is achieved, and not require anyone to claim credit for it, but just say, look what we can do when we enact this kind of program, and try to take it away from Obamacare, try to take it away from its just a democratic effort to take over the world, then we might actually make some progress in getting more people on board to do those small steps going forward.
So you would say like better education about the policies might be a good first step?
That's what I would say, and then I would also recognize, we can't even educate people about masks and vaccines, so it's a high hill to climb.
Arturo, do you have anything to add? I mean, I agree with Mark that if we had a good answer to the polarization, someone would be working in the administration to help message better, and it's still not happening. And even when the messaging is correct, there's a resistance to it that just makes it very, very difficult for all of us who are working in public health, who are working for social justice and for equity in society, that these issues meet with a wall of resistance that seems just insurmountable at this point in time. And I think I really appreciate Mark's bringing attention to the fact that we're also sort of at a tipping point that I don't think I'm spending a lot of time in retirement reading history, but I'd have to go back to ancient times to find periods where the tipping point seems as dangerous as it is today in terms of the vilification of the other side. And I think that that's just on a purely personal, not a professional level, the most troubling development I've seen in my lifetime.
And might I just add, to make it even more frustrating, Sorry. Remember that the Affordable Care Act came out of a change in the policy milieu between Clinton's administration and the Obama administration, and it was really absorbing ideas from a broad spectrum of people. And the fundamental structure of the Affordable Care Act, at least a significant part of it, had to do with the individual mandate, tax subsidies to make it more affordable for people to buy competing private insurance plans, some regulation of those plans. Go back and read Stuart Butler, Vice President of the Heritage Foundation, Mark Pauly, distinguished market-oriented health economist. They put that forward in the early 1990s. It was in the Republican
Platform.
the HEART Act. They had in the Senate.
Yeah.
It had 22 Republican sponsors, including the Republican leader Bob Dole, along with John Chafee, who put it together. Now, that was much less regulatory, much less expansive, but it was still on the playing field of where the ACA is. And then the Massachusetts plan grew out of that with a Republican governor and a Democratic legislature. By the time we get to the ACA, and certainly by the time we get to the Trump administration, suddenly that's socialism. Suddenly that's communism. Suddenly that is going to destroy the country. And I've got a whole series of quotes about how the ACA is killing people and killing children and killing old people, and it's the worst thing since slavery. And it's the worst law that's ever been passed in the history of time. It's just inconceivable that we've gone through that kind of transition. Now, how we pull back, that's the hard part.
But that is the shift that we've seen in the political sort of barometer, because Mark is absolutely right, and I actually assigned that in my ACA course, that report by Stuart Butler outlining basically the framework for the ACA in 1989.
Right.
I think the report was published. The structure was there. What's shifted is our political sort of environment, and that is what all of us, the challenge that we're facing moving forward. So it's not like me to end on a sour note. On the other hand, I'm looking at the clock and I'm not sure that we have time for any more questions. So I'd like to thank, first of all, my panelists for participating, and thank you for your kind words in tribute to me. Thank all of you for attending tonight. And we still have a lot of work to do, but thank you.
Thank you, Gary. Thank you.
I want to thank all of you for coming tonight. Jerry, thank you for everything that you've done and for everything that you will continue to do, both through the fellowship and through the fact that none of us are going to let you get very far away. I also want to remind all of you that this forum is possible through your donations, and we want to keep it public. We want to keep it free, and that, in Paul Torrance's mind, was really, the purpose of a public institution like UCLA. So I encourage you first to give to Jerry's scholarship, but then if you can find some coins in the couch cushions to consider contributing to the forum. Before you leave, please drop your magnetic name badge. There are students at the back with boxes. If you want to keep the part that has your name on it, go for it. But we want the magnetic ones so that we can reuse them again. Thank you all for coming tonight. Huge thanks to the panel. Thank you.
Thank you.